A 25-year-old female presents with a painless, hard, palpable mass on her finger. I am showing you an AP hand radiograph and a lateral view of the finger. Please describe the findings.
The radiographs demonstrate a well-defined juxtacortical soft tissue mass along the volar aspect of the phalanx. The mass contains punctate chondroid calcifications and causes smooth outer cortical scalloping of the underlying bone, bordered by a thin sclerotic margin.
What is your primary diagnosis?
The findings of a benign juxtacortical mass, causing smooth saucerization of the underlying cortex, with a sclerotic margin and punctate calcifications, are diagnostic of a periosteal chondroma.
What is the cell of origin and the typical skeletal distribution of a periosteal chondroma?
Periosteal chondroma is a benign hyaline cartilage tumor that arises from the deep layer of the periosteum. It has a strong predilection for the small tubular bones of the hands and feet, followed by the proximal humerus.
What is the classic radiographic term used to describe the smooth cortical erosion caused by the pressure of this slow-growing surface tumor?
This cortical erosion is classically termed saucerization. The slow growth of the tumor allows the adjacent cortex to react and form a thin sclerotic border or bony buttress at the edges of the lesion.
How do you distinguish a benign periosteal chondroma from a malignant periosteal chondrosarcoma?
Periosteal chondrosarcoma typically occurs in older patients, is much larger, usually exceeding 5 centimeters, and demonstrates aggressive cortical destruction, medullary invasion, and lack of a well-defined sclerotic border.
Does a periosteal chondroma typically invade the underlying bone marrow cavity?
No, a periosteal chondroma is limited to the bone surface and does not invade the medullary cavity, which remains normal on both computed tomography and magnetic resonance imaging.
What other surface bone lesion of the hand should be considered in the differential diagnosis, particularly one showing histographical cartilage cap?
An osteochondroma or exostosis should be considered. However, osteochondroma is distinguished by the direct continuity of both the cortex and medullary cavity of the host bone into the lesion, which is absent in periosteal chondroma.
Finally, what are your clinical management recommendations?
I recommend complete marginal surgical excision or curettage. It is important to achieve clean surgical margins because incomplete excision can lead to local recurrence.